All right, thanks again for joining us for today's presentation on the causes and symptoms of bunions and hammertoes, what you can do to help relieve pain, and when you should talk with a doctor. And now I'd like to introduce our speaker this evening, Dr. Hayden Hoffler. Dr. Hoffler is a board-certified, fellowship-trained foot and ankle surgeon specializing in the treatment of foot and ankle disorders. He believes that education, empathy, compassion, and respect are characteristics that help to build a well-rounded practice. He takes a multidisciplinary approach to a wide range of problems, including forefoot and rear foot deformity correction, minimally invasive surgery, tendon and ligament repair, as well as lower extremity trauma. So thanks for joining us today, Dr. Hoffler. We're glad to have you.
Thanks for having us. This will be a great talk.
Excellent. Now I'd like to turn it over to you for today's presentation.
All right. Well, good evening, everyone. Thanks for joining, and thanks again for the kind introduction. Once again, my name is Hayden Hoffler. I'm originally from Charlotte, North Carolina, and I've managed my way up the East Coast into the Baltimore area. And once again, thanks for having me. So today we're going to talk about bunions and hammertoes. So just some objectives from tonight's talk on bunions and hammertoes. So just the cause and etiology of them, how bunions and hammertoes are actually diagnosed, both clinically and radiographically, meaning x-rays, understanding the treatment options for both of them, both conservative and surgical, and then understanding what to expect following surgery if it comes to that point. All right, so we're going to start with bunions. So what exactly is a bunion? So in my terms, I call them medical terms. A bunion is a triplanar deformity consisting of displacement, rotation, and deviation, whether it's dorsal, planar, or both. So you can see on the picture on the right, that's a pretty severe deformity that has multiple planes involved. Most of the time, patients described it to me as just a bump on the inside of my big toe. And so just some basic anatomy. There's a lot of words on this slide, and the biggest thing to take away is that the big toe complex is composed of a variety of ligaments, tendons, and two bones that make it up. And you can see in the lower left-hand corner in a bunion, some of the tendons are pulling the toe to the opposite direction or the outside of your foot, causing that medial bone to be exposed, leading to a loss of balance between the tendons and further deformity. So causes. What are some causes? Believe it or not, Usain Bolt, who's the world's fastest man, has a bunion. And so how did he get it? So there's a variety of reasons. Number one is just pathobiomechanics. Now, what does that mean? That's just foot type. Bunions are more prone in people with flat feet, but it can happen in all foot types, whether you have a regular arch, higher arch, or even a flat foot type. Arthritic conditions. Sometimes arthritis can kind of push the big toe over, whether that's inflammatory or just degenerative from just overtime and overuse. The biggest one is genetics, and you can see it in red. It's highlighted for a reason. Most of the time it's from mom or dad, so you can usually thank them. So in Usain Bolt's case, you can probably thank them. Trauma is another one. Whether you have a big toe injury, something drops on it, you stub it the wrong way, that can lead to a bunion as well. Neuromuscular diseases, something that you can be born with or generally get over time, can cause them. And then lastly is Charcot, which we see more commonly in our diabetic population, can actually have a bunion deformity or cause a bunion deformity. So how do I actually diagnose them when you come to my clinic? The first thing I do when I see a patient is I actually watch them walk into the room. That gives me a good idea of how they actually feel, where the actual pain is. Do they have any calluses associated with it, whether that's on the bottom of the foot, on the inside of the foot? You can see here in the bottom left. On the outside of the foot, what other deformities do they have? Do they have hammer toes, which we'll talk about later? Do they have a higher arch, a lower arch? Do they have any nerve conditions that are related to it? So there's a variety of factors that I take into account when actually diagnosing a bunion. But the biggest thing is actually seeing that bump on the inside of your big toe. Next thing, after I see it clinically, the biggest thing in determining kind of surgical procedures, if it gets to that point, or even the severity of a bunion, is looking at x-rays or radiographs. And you can see in the picture on the top left corner how the big bone, which is called your first metatarsal, is kind of going to the inside while the toe is going to the outside. That's usually what a bunion looks like. A good example of clinically and radiographically or x-rays is on the lower left, where you can see the toe going outward and you have that big bone going inwards, and then again on the right side. And I get multiple different views. This is the most common view to actually see one, but multiple views are taken into account. So treatment options. Majority of bunions can actually be treated, conservatively or relieve some of the pain temporarily. So surgery does not have to be done. There's a lot of things that can happen with this. That can include padding, whether it's padding outside of shoes or with shoes. Inserts can help. Most people ask, how can inserts help a bunion? Well, it can actually control foot motion, therefore leading to less irritation through the big toe joint. Wider shoes or shoe modifications. You can see on the upper right portion of the screen, someone's actually cut holes in their shoe to relieve a bunion. Splinting. Splints help as well. Icing or just anti-inflammatories. Sometimes with actual pain, you just need to decrease some of the irritation you're having. So just anti-inflammatories or icing can help as well. Injections, a lot of the time, if there's an arthritic condition associated with it, or just pain with moving the joint, an injection can temporarily relieve it. And then the last thing is larger shoes, whether that be length or width, as mentioned above, just giving more room without cutting a hole, as seen in the top right, can actually relieve it conservatively. So treatment options, there's over about 200 options for treating bunions surgically, dating centuries ago. I've listed the 4 big topics for treating bunions. The first one being exhaustectomy. Essentially, that means shaving off the bump. So you can see in the top 2 pictures on the left, you can see a mild bunion, or I call less severe, followed by a shaving. The next is an arthroplasty, or creating the joint, and that's for a certain type of population. We're actually cutting portion of the bone out to help swing the toe over while relieving some of the motion. Osteotomy, which is the most common, which involves breaking the bone and shifting it over, and that can involve an open incision or some of the newer techniques, such as some of the ones I'm doing called minimally invasive surgery, which are smaller incisions for a better cosmetic look. And then the last thing is actually fusion, and that can involve fusing the toe at the great toe joint or the joint behind it. And you can see on the bottom, there are 2 examples of that, where there's fusion actually at the big toe joint and the joint behind it. So either one of those are options. So what option is best for me? I always tell patients there's 4 big factors to consider for surgery. Number 1 is the severity. So you can see the scale on the bottom. Bunions can be mild and they can also be severe. And I also tell patients that a very mild bunion can cause just as much pain as a severe. I've had patients who had the most severe, grandma's a great example, had the most severe bunion I still today had ever seen, but she was in no pain. And I've seen some very mild bunions, they're very painful. So it is patient dependent. Age is another factor. Is there arthritis involved? Are they very active, such as, playing pickleball lately? Are they playing tennis, basketball, soccer? And are there other deformities? That's the big one. Do they have hammer toe deformities? Do they have a hindfoot deformity, meaning towards your heel bone? Are they flat-footed? Are they high arch? All those can be contributory to which option is actually best for my patients. So what can I expect post-operatively? We'll dive in a little bit, of each procedure, but in layman's terms, it just depends on which procedure. Generally, you're either in a boot or a shoe, or a splint or a cast post-operatively, but it is procedure dependent, as each procedure has different protocols. So the first treatment option, or the first category we talked about, is exhaustectomy, or shaving off the bone. Usually that's for mild bunions where the pain is just on the inside of the big toe, with no associated deformities, where the inside bone is essentially shaved off, and sometimes there's some capsule around it that's actually tightened up to help correct it as well. Those patients are usually walking in a surgical shoe, full weight bearing, right off the table. So as soon as you leave, PACU, you're walking home, which is great. Unless it's a right side, you just cannot drive. So I always emphasize that. The next option is osteotomy. So that's the most common. And as you can see here, it's done a variety of ways. There's, just like I described before, hundreds of osteotomies throughout the first ray, which is essentially the big toe and the first metatarsal, that can correct bunions. Some are opened up with large incisions, some are smaller incisions. So it just depends on the patient's number one preferences, but those various factors that I described previously. And you can see on the left, so there was a toe osteotomy and a first metatarsal osteotomy done. And that was an open procedure versus the one on the right side, which was done minimally invasive with just small incisions, which was great for skin healing. So generally kind of the same as an exhaustectomy or shaving off a burn, where you're actually walking the same day. And it just depends on other procedures that are performed. But if it's just focusing on the bunion, you're walking the same day in about a shoe for about 4 weeks and then back into regular shoes. Next option, arthroplasty. This is definitely the least common. This is more or less for older patients who just have irritation at the joint. Some are use that K-wire. Sometimes I don't, and that just depends on the stability of the joint. A lot of the times, if there's a plantar callus, this procedure is an indication, and it's similar. You're walking in a shoe or a boot, which is great. And then lastly is arthrodesis. Like I talked about, there's two joints that can be evolved. There's either the big toe joint, seen on the right picture, or the first metatarsal cuneiform joint. Either are great procedures. It just all depends on those factors I talked about. With any fusion, I'm very strict with the postoperative protocol because you do want that joint to fuse and heal the first time, as complications can happen with any procedure. So generally with my fusions, you are non-weight bearing for 6 weeks. Now that's not 6 weeks in a cast. That doesn't mean you stay in your bed the entire time. That just means you cannot put weight on it. That's what non-weight bearing means. So you're generally in a splint off the table, followed by a boot at about 2 weeks. And then you're walking at 6 weeks and generally regular shoes between 6 to 8 weeks. Alrighty. And so this slide, I wanted to show just some pre and post ops of some of the procedures of the variety that I've done, because there's quite a variety on here. And patient consent was obtained to show these, and markers have been removed for that purpose. So with the fusion options, I put them on the left side just to demonstrate the variety of constructs that I use. It's all the same procedure, whether you use a screw or a plate or even a staple and even wires, it's the exact same procedure. That's what I always tell patients. The protocol is the exact same. The hardware does not buzz in the airport as well. That's worth mentioning. So you can see on the left side, I performed that first tarsometatarsal joint arthrodesis. So not at the big toe joint, but actually back at this joint, because it's actually shown that bunion deformities stem more from this joint than actually up in this area. And so you can see quite the difference. And a big indicator I'm actually looking at is the sesamoid position, which are these two little things that look like eyeballs is what I call them. And you can see quite a difference in how straight the toe is. On the bottom left, this is a fusion performed in someone who's a little bit older with a little bit of arthritis and joint pain in the area. So I decided to perform a fusion. In her case, she did great. The hardware has stayed in without any issues, minus the wire, which comes out at 6 weeks. So I do mention that if there's a wire, which we'll get into with Hammertoes, that comes out at about 4 to 6 weeks. So her correction was great. And on the right side, we've got some osteotomies. So you can see the difference on the top right. One that just had a mild bunion deformity where just a small shift was needed to correct. And you can see just one screw was needed there. And that was an open incision. And then for comparison on the bottom, you can see the correction was a little bit more. You can get a little more correction with minimally invasive surgery, but the incisions were smaller. So there's no scar on her to this day, which she's very pleased about. And she also had a hammer toe as well, and another associated procedure with the metatarsal. So you can see there's a variety of procedures. It's not just one procedure. I think that's the biggest misconception with bunions by taking a bunch of different factors. So that's something just to keep in mind when seeking opinions on bunion procedures or even speaking to me about it. I'm very open about which procedure is best for patients. And Kelly, do anyone have any questions so far?
Yes, we do. That was a lot of great information. I'm definitely learning a lot myself for this presentation. So first question, Do bunions typically get worse over time? And is it wise to see a doctor at the very first sign of bunions to have it monitored over time?
So yes, they can get worse over time. A lot of factors that can cause that are pretty much tight shoes and foot structure if that gets worse over time, and that's just more or less wear and tear. I always tell patients as soon as you feel like there's some sort of irritation or even just cosmesis, something doesn't look right, it's best to just get it checked out. Um, the biggest comment I probably hear from my patients is, I wish I came in sooner. So I would recommend if there's any issues or any concern about it at all, whether it be minor or major, to come get checked out.
Great. And around when do bunions usually start appearing? Is this something that like kind of develops early on in life, or is this something that can develop, as people age into their 50s, 60s, and so forth?
So they can be either. I've done procedures in children as young as 12 to 14 and as old as about 80. Like I said, you can actually be born with them, being a congenital deformity. So you can see it in all ages.
Okay. Would you recommend doing bunion surgery on both feet at the same time, or just one and then the other?
I would recommend no, unless it's purely just shaving off the bone. The reason why, not so much for ambulatory, because you're walking if it's a less severe deformity, but for more or less pain. I always tell patients, if you're interested in having them on both feet and they're about the same pain level, do the left one first. And the reason why I say that is you can drive right away. So you can get used to having surgery with driving, so you know the expectation going in. But if you have them on both feet and they're about the same, or not about the same, excuse me, do the one that's bothering you worse.
Makes sense.
And that doesn't necessarily have to be the one that looks worse. I always tell patients, do the one that you feels worse. One can look a lot worse and be in no pain, and one can be looking only like a minor deformity and be in a lot more pain.
Absolutely. Is it true that after some bunion surgeries, the bunion can return, or is it once the surgery is over, that's a lifelong fix?
Correct. Yeah. So bunion recurrence, and we'll get into that towards the end of the slide, is complications do happen, and recurrence actually is more common than people think. I tell all my patients bunion surgery is about a 90% success rate unless you're having a fusion of the big toe. The fusion of a big toe is about a 95% success rate, which is the highest successful procedure for bunions um, on the feet. So about 10% of them, if not more, can come back. And that's not only due to the procedure, that's due to compliance, other factors as well can lead to that.
Okay, great. Do bunions only occur on the big toe? And if they can occur on other toes, does the information apply or provided so far apply to all other bunion locations?
So bunions occur on the big toe, and something called a bunion net, which is a smaller bunion, occurs on the fifth toe, or just proximal to the fifth toe on the outside of your foot. So bunion is a term used for a bump on the inside of your big toe, and bunion net, which is called a tailor's bunion. Tailors used to get them back in the day from sitting on the side of their feet, which is why they got the name, is a smaller bunion on the outside of the foot.
Perfect. For the procedure itself, is this an inpatient or an outpatient procedure? Can you talk a little bit about like the average time the procedure takes and like what kind of sedation is used?
Absolutely. So as long as the patient's healthy without any significant comorbidities, it's an outpatient procedure. Most of them are done at the surgery center. Some of them are due to the hospital due to block time or restrictions. Bunion procedures can, take as quickly as 5 to 10 minutes. Some of the fusions take about 90 minutes or even up to 2 hours, and that depends on what other conditions are available as well. If there's hammer toes or a flat foot, high arched foot. Um, so there's a lot of things that take into that account. With regards to sedation, generally for bunions, if it's a fusion, it's more or less general with local. Now, what that means is essentially I'm numbing the foot and you're put to sleep. With the less, I call them invasive procedures, so the osteotomies or shaving off the bump or just straightening out the toe with soft tissue deformities, those are more or less just lighter sedation with local or me numbing your foot.
Okay, great.
So they're generally not heavier sedation. They're generally more on the light side.
Gotcha. And I know you mentioned earlier, but can you repeat the kind of timeline for recuperation in terms of how long it takes for people to be back to like full functioning and walking?
Yeah, absolutely. Yeah, so for the osteotomies and some of those smaller procedures or just shaving off the bump, you're walking home from the operating room in a surgical shoe. Generally, you're in that shoe for about 4 weeks. Then you're back into regular shoes. And I always tell patients full recovery is 3 or 4 months. That's not just with bunion procedures, that's anything I do for the foot and ankle. So with that regards to, full running and jumping. But generally, walking in regular shoes at 4 to 6 weeks. With the fusion, like I said before, it's 6 weeks of non-weight bearing. That does not mean bed bound. That just means you have to stay off of it. So generally 2 weeks in a splint for me, and then 4 weeks either in a boot just to allow you to shower, itch, all the essentials, or a cast sometimes as well for more invasive procedures. Walking in a boot at 6 weeks and then regular shoes generally around 8 weeks or so. But the full recovery, 3 or 4 months, is what I always tell patients. And the biggest thing you have to take into consider is that swelling and pain, which is part of the postoperative recovery process, whether it's a toe or an ankle, can be there for up to 6 months, sometimes even a year. So um, full healing can take up to a year after this procedure, which is why I tell patients if you want to wait about 6 months or so in between procedures, that's generally where you want to wait if you're interested in doing both.
Perfect. Thank you for that. Can you just talk a little bit about like we talked about several different treatment options for bunions. Is Lapiplasty also a treatment method for bunions? And if so, how does it differ from the ones you've discussed so far?
Absolutely. So Lapiplasty is actually the same procedure that I was showing earlier, which I'll go back to. So essentially, it's the same procedure as this. It's just different hardware being used and using a jig. And that's all it is. It's the exact same procedure as this. You're fusing the first tarsal metatarsal joint. But you see it a lot in the marketing. Yes, I do it 100%. But like I said, there's patient factors that are involved with that as well. But yeah, it's that I do the exact same procedure. It's called a lapidus bunionectomy.
Perfect. All right, let's take one more question related to bunions for now, and then we'll jump into our next topic in the presentation tonight. So this is kind of a general question relating to other methods of treating bunions aside from surgical options. So there's a variety of products on the internet that, claim to have success with reducing the size of bunions, things like that. Is there anything like that that you found to be successful, or is it kind of just like a placeholder?
There's some things that are generally, I would say, somewhat successful, but you have to be careful with those because a lot of them are, marketing their own product. Generally, it's wider shoes and actually just putting spacers in between the shoe gear and sometimes even inserts. You're just trying to provide relief to the area. Are those products going to correct the bunion? Unfortunately, not. The only way to correct it is actually surgery. And as much as I love doing surgery, I want to treat these as conservatively as I can because there's a variety of options that are out there for it. But yeah.
Perfect. All right, let's pause there on the questions and let's go ahead and talk a little bit about the next topic, and then we'll circle back for some more questions at the end.
Alrighty. Great. So now we're going to talk about hammer toes and what all is involved with hammer toes. So what exactly is a hammer toe? So in my terms, a hammer toe is a deformity of the toes where they're bent due to imbalance in tendons. A lot of the terms that patients use when they see me is their toe is either stuck, bent downward, or even bent upwards. So you can see the picture on the left. There's probably hammer toes of 2 through 5 on both feet, I would say. You definitely can build a house with those things. And top right, you can see LeBron James, probably the most famous basketball player, if not one of the most famous athletes in the world. That's a picture of his live feet. Yes, he does have hammer toes. So just some basic anatomy for a toe. There's a lot of stuff involved in toes, believe it or not, as well. The biggest thing being bones, tendons that are over and underneath the toe. And those are both your extensors, which are located on top of your toe. So those are the tendons that pull your toe up, and then the flexors that pull it down. So essentially in a hammer toe, you could see on the bottom picture, one of the tendons is pulling the toe up and the other tendons is pulling it down, causing it to curl. Ligaments are involved as well as the capsule. And those are important because that can cause your toe to actually overlap, whether it be your big toe, your third toe, fourth toe, fifth toe, or even the big toe overlapping as well. So everything's involved in a toe, whether that be tendons, ligaments, or even capsule and bone. So different types. So believe it or not, hammer toes can present in a variety of ways. And I thought this slide was important because it's not just at one particular joint where hammer toes can occur. Hammer toes is a name just for, pretty much a bony protuberance at the proximal joint in your toe. And that's what I'm talking about here, but they can occur a variety of ways. So it can look like kind of like a claw in a bird where you actually have flexion at two joints in your toe. So there's two joints in your toe and both of them can be essentially flexed down, causing a claw toe. There could just be one toe, just like the hammer toe, just at the proximal joint, or even a mallet toe, which essentially looks like a mallet where it's only hammered down at the end. So they can present in a variety of ways. So what are the causes of? So what causes some of the pictures that you're seeing here? The biggest thing, just like I talked about, loss of, muscle and tendon balance. And that can be due to biomechanics, foot structure, flat feet, higher arch feet tend to cause these a little bit more. Neurologic disorders that might cause some toe contractures, whether you're born with them or get them over time. And that could be something like as simple as a stroke. Trauma as well, a toe injury, due to something falling on it or stubbing it could cause the toe to actually permanently hammer down. Inflammatory process, a lot of that time is arthritic conditions. So psoriatic rheumatoid arthritis, some of those conditions can cause the toe deformities as well. And then lastly, just the basic anatomy of the patient, just like we talked about previously, whether that be foot structure, that could be, some of the demographics that the patient has as well, whether that be diabetes, obesity, things like that can sometimes cause it as well. Just for completion purposes, there's three main causes from the muscle tendon imbalance that are labeled there before, which pretty much demonstrate how the toe moves up and down. All right, so diagnosis. What do I do when coming to my clinic? Kind of similar to bunions. I want to see you walk. I want to see how the toe moves when you move. I also take a look just standing or sitting in the exam chair. How is the toe sitting? How do I determine, what procedure, if it gets to that point, or what conservative treatment to try is determined by the picture on the right side, where sometimes I push up on the bottom of your foot, or sometimes even flex and extend the toe. And if it can't extend, that essentially means it's a rigid deformity, meaning the toe cannot be straightened out. And that determines kind of the treatment option that you'll have for that. You can also have toes that cross over, just kind of seen on this picture here, whether that be the ligament or capsule that's pulling that toe over. So there's a variety of things. Sometimes they'll have calluses, whether that be on the top of the toe, the end of the toe, the inside, just like we talked about with bunions as well. You can also have them within the inner space that can irritate it, okay, as well. And then nerve related, I always exam for in nerve pathology because there's nerves running on each side of the toe, and there's a lot of toes on both feet. So sometimes it can be a nerve component that sometimes you can just miss. So similar to bunions, x-rays are important as well. You can see on the top right picture, you can not only see the toe crossing over here, but you can see it going up in the air, just like a traditional hammer toe. I do order MRIs sometimes. And the reason for doing that is in analyzing something called the plantar plate, which is this on the bottom of the two toes, which essentially holds the toe together and keeps the toe straight, and sometimes from the toe bending down as well. So sometimes if there's a concern for a plantar plate injury or even a capsular injury, an MRI is sometimes needed if some of the conservative measures are not working. So now diving into treatment options, conservative options for hammer toes. So what should we try first? I call these toe sleeves, where your toe kind of looks like the mummy, where you just simply slip it over. If patients are looking just for temporary relief or even just to prevent irritation, whether that be in shoe gear, sometimes when you're sleeping, that can be an option. There's splinting as well, such as here, where you can actually pull the toe down. There's something called a crest pad here, which essentially pushes your toe up while pulling it down to help straighten it out. Metatarsal pads help as well to help offload that forefoot, whether it's the left side or the right side. Similar to bunions, you want to have larger shoes, or at least try larger shoes. Extra depth shoes, essentially that means your toe box, where your toes are, is a little bit larger, just to accommodate for some of the irritation you might be having. Sometimes the toes might have calluses that just need periodic debridements. So that just means shaving down the calluses. And sometimes that just give the patient some of the relief they need. And then similar to bunions as well, injections can temporarily or permanently sometimes even solve the pain they're having. All right, so now diving into the surgical procedures for hammer toes. So similar to bunions, there's a wide variety. For hammer toes, luckily there's a stepwise process that I take for this, and it's divided both into soft tissue and bony procedures, as you can see on the left side. So soft tissue, there's multiple different options. Flexor tenotomy, which we'll jump into, is releasing the tendon. Capsular release, which is more or less at the joint back in this area. Tendon transfer, which we'll talk about as well, which is just a small tendon in the toe, believe it or not, that can be transferred. And then there's the bony procedures. So arthroplasty, meaning creating a joint. Arthrodesis, similar to bunions, that means getting rid of the joint. And then believe it or not, amputation is an option as well. So let's dive in. So first thing, flexor tenotomy, what that actually is. So remember from the slide previously, there's a long tendon that runs on the bottom of your toe. For these flexible deformities, meaning I'm able to straighten the toe out without any irritation or resistance from the bone sticking out, are a good option for a flexor tenotomy. I used a lot in my diabetics who have ulcers at the end of the toes from a hammer toe deformity. This is just one of the ways you can actually do it. And some of my patients have had it done this way. Others, there's a little knife that you can stick in as well to help release that tendon. I do it in the office or the operating room. Your toe's completely numb and you're walking the same day. But usually the effects are pretty immediate for that, which is great. So next into the soft tissue procedures, we've got capsule release and plantar plate repair. So capsule, just like we talked about, is the soft tissue kind of lining, similar to you have lining in the knees and hips, shoulders as well, that helps protect it. Sometimes the capsule can be irritated or further cause the contracture. So if needed, it just gets released. So the incision is lengthened a little bit and the capsule is relief to help bring down the toe. Plantar plate repair. So remember how I was stating how the toe can go to the inside or the outside, up and down. Sometimes with MRIs, if a plantar plate is found to be torn, both clinically and on the MRI, sometimes a plantar plate repair is sometimes needed. Tendon transfer, so the big ones, flexor digitorum longus tendon transfer, where the tendon on the bottom, you can see here, is actually broken into, I call it a Y or a V formation, and actually wrapped around each side of the toe. In addition to some of the other procedures that are done, it can be done in an isolated procedure. I usually don't, but it works great by reducing that flexion force that you have by bringing the toe down and helping it actually bring the toe up and straight. Arthroplasty and arthrodesis. So remember, creating a joint and getting rid of a joint. This is the most common. These are the names on the top right, what they're actually from. Essentially, it involves taking out the knuckle of bone, as you can see there, and actually using a K-wire or a pin down the center of your toe. And you can see that both clinically on the left and radiographically down the right to help straighten out the toe. And as I said previously, generally they're kept in for about 4 to 6 weeks. You don't want to have them pulled earlier because the toe can go back to the same position. So you want to have everything in that healed position for 4 to 6 weeks so it can scar in before taking it out too early. And last but not least is amputations. Amputations are a good option. I use it more or less in the elderly population, sometimes recurrent hammer toes, which do happen as well, which we'll get into, can lead to this as well. This is not a primary procedure I use. There's very specific population that uses it, and it's mostly used in the elderly folks that I have who simply just want the immediate pain relief. And it has the quickest recovery. I always tell patients it is an option, whether you're 20 or 80. I'm not biased for any age group, but it is the last option I give patients. So once again, here's some of my cases. I obtained consent from each of them without any identifiable factors here. So on the top side, you can see a big old hammer toe. It was sticking straight in the sky when I saw it in clinic. believe it or not, and bringing down, and it was actually bent to the side. She had a big severe bunion as well that I corrected, and you could see this is a non-weight bearing film, but the toe is completely down. I always put the toes down in a plantar flex position. That means put it down below the big toe. And essentially the reason why I do that is because when you pull the pin, the toe slightly goes up into the correct position. So, and then on the bottom, a similar thing, I had a patient who had a bunion, or excuse me, had a hammer-toe deformity, which I corrected. And they just had an isolated second toe deformity, but you can see the contracture here that was corrected with a pin, which was eventually pulled. And these were associated screws with another procedure. So just kind of wrapping up both topics, and then we'll get into further questions on either or one. When to actually see a foot and ankle specialist. As Stephen A. Smith would say on the top right, the biggest thing is pain. Anytime there's pain, I think it's warrants seeing a physician. Irritation in shoe gear, whether that be sandals, flip-flops, closed-toed shoes, cleats, even hiking boots, especially given the summer when everyone's more active. Stiffness in the toes, whether that be the big toe joint or the lesser digits. And then cosmesis. Do you just simply want the bump to go away because it doesn't look right, as the lady would say on the bottom right? That's an option as well. So when to consider surgery. So there's three big reasons when I tell patients to consider surgery, and I always encourage all patients to exhaust all conservative options or the non-surgical treatment options before leading to surgery, because I think every surgery is a big surgery, whether it's a toe or an ankle. And so I always tell them severe pain, anytime it's causing you to constantly touch your foot or not touch your foot due to the pain, that's a reason. Is it affecting your daily activities? Is it affecting you to go down the stairs? Is it affecting you when you get up and use the restroom or take out the trash, mowing the lawn, things like that? And then is it causing you to limp or walk differently? Some patients have come in and see me with canes because their bunions or toes have hurt so bad. Or is it causing you to limp or compensate by putting more pressure on the other side? Those are the three big reasons. Not to say there aren't any more reasons, but those are the three big reasons to consider surgery. And then now what? After surgery, what do we do? So when you walk, I always tell patients, because there's a variety of procedures, both bunion and hammer toe. It depends on the procedure or procedures involved. Remember, they can be multiple procedures performed with both bunions and hammer toes and the rest of the foot. So it does depend on that. So there's not one certain time frame, unfortunately, for them. Like I said previously, it's 3 to 4 months for full recovery. Pain and swelling and stiffness can last up to a year. So remember, I said that before, that it can happen. So unfortunately, they can't just be healed in a couple weeks. I have had patients that are pain-free from day one, but some can last for up to 6 months or even a year. And then lastly, I always mention to all of my patients, just like we talked about bunion recurrence, complications can happen, whether that be an infection, something doesn't fuse, there's hardware that's painful down the road. Complications happen with any surgery, whether that's foot and ankle or the rest of the body. So I always mention that to all of my patients. Unfortunately, I cannot say that there's a 100% success rate with any procedure. I wish there was, because I would be right there doing it. So just keep that in mind as well. So thanks again for me. This is just a little bit, this is my family right now. This is my wife and I. We just got married, and our Labradoodle, her turns 5 any day now. And now, Kelly, do you want to take questions, the rest of them?
Absolutely. Beautiful family. Thanks for sharing the
Yeah,
pictures.
thanks.
Yeah, we've got a bunch of great questions coming in here. That was a lot of information, a lot of good stuff to learn here. So let's start with, so with hammer toe, a lot of the pictures that you showed had the second toe kind of leaning over the big toe. Is
Mhm.
it still considered hammer toe if the second toe curves the opposite way and goes over the other small toes?
Correct. Correct. I call it a crossover toe.
Perfect. Um, are there any spacers that can be used like in your shoe in everyday life if you're not at a point where you're ready for surgery and just are looking to try something to kind of correct on the day to day?
Absolutely. And they're made from a variety of a material. It could be gel, it could be rubber as well. But just like I mentioned previously, spacers can help. Just be mindful that you potentially will need a wider shoe as well, because it can cause a toe to kick over, which means your foot gets a little bit wider. So just keep that in mind.
Okay, great. And are there any particular like shoes that are made for issues like this, like a hammer toe or bunion, any particular types that are more beneficial than another?
Yeah, absolutely. So the two shoe types, regardless of whether it's a bunion or hammer toe, that I recommend to my patients are Hoka's and Brooks. They're the most supportive. Hoka's have the largest toe box, so I recommend those for bunions and hammer toes the most because they give you the most space. So there's less likely to be irritation.
Perfect. And does like the arch of the foot or lack of it have any impact on like bunion or hammer toe formation? Like if you wear shoes that don't have arch support or something like that, is that a contributing factor for either of these?
Absolutely. Yeah, if we take back to one of the earlier slides in bunions, pathomechanics or having a flat foot can cause something called hyperpronation, where your foot rolls in from lack of an arch. So sometimes even arch supports rather than inserts, I tie them together just to control that motion can prevent the irritation from happening.
Okay, great. And just circling back on the shoe brands that you mentioned, that's Hoka's Hokas.
Yes, Hokas and Brooks, Brooks.
Perfect. Thanks for clarifying.
Yeah, absolutely.
Is there any benefit to yoga or any like realignment exercises of the foot that you can do like as a stretching kind of thing that would help with either of these?
I always encourage that. The problem with that, it has to be continuous. And unless you're doing it on a daily basis, unfortunately, most patients aren't, meaning 24/7 for 20 or 30 years. The bunion is most likely not going to get better. But they do help with just general strengthening and range of motion of the toes. Yes.
Perfect. So in regards to surgery for hammer toes, is the hammer toe surgery like on a pinky toe more painful due to pressure from walking, or is it kind of like across the board?
It's equal across the board. Equal across the board.
Okay. And can you talk a little bit about like the post-surgical, like what to expect for hammer toes? I know we went over like a lot of the timeline for bunions. Is it the same kind of thing for a hammer toe correction surgery?
Yes, it's the exact same. Um, if it's just a hammer toe procedure being done, meaning no associated procedures, there's no period of non-weight bearing. So you are walking in a shoe or a boot from day one. Generally, I see patients back for all procedures at 1 week, 2 weeks, 6 weeks, and 10 weeks. And during that time, that kind of determines what next steps are taken. But for hammer toes alone, if we were just doing strictly hammer toes, you're in a shoe for about 4 to 6 weeks. If there's pins that are coming out of the toes, those are pulled between 4 and 6 weeks, and then you're in regular shoes.
And do the boots that you get after hammer toe, like if you have pins in, does the boot kind of protect you? Like have on a large capsule on the front end to protect the pins from getting jostled?
Some of them do. For other reasons, I actually cover the ends of them for that reason.
Okay, cool. Are hammer toes genetic?
They can be, yes.
Okay. Um, and how do like a bunion or a hammer toe, how do they usually develop? Like if when you're first starting to notice signs of them, is it like a quick onset? Like once you start to notice it proceeds rapidly, or is it tend to be a longer term process?
Generally, it's a more long-term process unless it's due to, something like a quick trauma. But generally, it's just generally increasing over time. And then you can either see the toe drift up or down or toes the side.
Okay. And that dovetails perfectly to the next question. Can, like, if you break a toe and it doesn't set properly or you don't get it treated correctly, can that develop into a hammer toe?
Absolutely. And believe it or not, the procedure is the exact same, which is great.
Okay, wonderful. For either bunion or hammer toe surgery, is there any medication that's prescribed after surgery, such as antibiotics or pain management, that sort of thing?
I do not routinely prescribe antibiotics afterwards, but I always give my patients three things. I give them pain medication, um, and that's taken generally, every 4 to 6 hours. I give them medication for nausea and vomiting, and then also for stomach irritation and constipation. So I call it the triple threat. I make sure everyone's taken care of, and I make sure all my patients have it before they go into surgery so that they're prepared and there's no medication complications afterwards. That's very important to me and something I learned over the years. So I try to take care of everything before.
Perfect. So if a person has hammer toes that aren't causing any pain, should they still consider a surgical solution, or is this kind of like a bunion situation where you can, if it's not causing pain, you can live with it?
Correct. Yeah, I would strictly not do hammer toe surgery purely for cosmesis. Same thing with bunions. If you're not in any pain before, I always tell patients you're most likely going to be in pain afterwards. That's not a guarantee, and I just cannot, emphasize that enough.
Okay. And during the procedure for hammer toe, are you put completely to sleep for the procedure? Is it like an inpatient, outpatient type procedure like we have with bunions?
Yep, the exact same. Generally, it's just lighter sedation, and then I numb the area around your toes so you're not feeling a thing.
Perfect. Can you describe like the initial symptoms when a hammer toe first starts to form? Is it something where you notice like the top joint begins to move, or like what kinds of things should you be on the lookout for like early stage hammer toe?
Yeah, I always tell patients, if you're looking at your toes from top to bottom, if one toe's going, or I call it drifting over another or going to the side, or one toe sitting up a little bit higher or even lower than others.
Okay, perfect. Um, for bunion and hammer toe surgery, is this something that's typically covered by insurance?
Correct.
Perfect. And does a patient need a referral to see a podiatrist, or is this something that if they're having a problem, they can schedule directly with you?
Correct. It's generally a referral.
Okay, perfect. From your primary care?
Correct.
Okay. Perfect. And so after surgery for a bunion or hammer toe, I know we talked a little bit about the recovery timeline, things like that. Is there any additional like exercises, PT, like any kind of therapy or things like that that you would recommend to kind of help get people back up and moving more quickly?
Yes, absolutely. So, generally, if it's a joint sparing procedure, meaning for toes, you're not having a wire in your toe, or for bunions, we're not talking about a fusion. I generally have patients, move their toes at around 2 weeks or so. That'll prevent stiffness long term. Obviously, with a fusion or having a pin, you're unable to do that. When those come out, or you hit that weight bearing portion, when you start to walk, 6 weeks, if indicated, or if weakness is present, physical therapy or even home exercises or both are actually prescribed and given to patient.
Wonderful. Well, it looks like that is all of the questions we've had from our audience today. It was a lot of great questions. So thank you all for your input and contributing to the presentation today. Um, so I think if there's no further questions, I think we'll wrap things up here. Dr. Hoffler, is there any, final words, final like closing statements you'd like to make?
Yeah, thanks everybody for your time. Once again, if you have any issues at all, um, we'll be able to, arrange contact information, and any severe, obviously, questions and things like that will get answered down the road. Once again, if there's any, problems that you're noticing, don't hesitate to reach out to any foot and ankle specialist, um, to talk about both conservative and surgical options. And like I said, our office number is on this screen here, so you're more than happy to reach out to schedule an appointment, and I'm happy to take a look.
Excellent. Well, thank you so much for your time and expertise and sharing all this information with us tonight. And thank you everyone for attending and sharing your time with us. So as Dr. Hoffler says, if you think of any additional questions or you'd like to get more information, you can reach out to Dr. Hoffler's office at the number on the screen. It's 410-644-1880. And you can also find more information on ascension.org.